Hello and welcome to Medical Dialogues. I am Dr. Nandita Mohan and today I have a very interesting discussion for you all. I will be talking about the recent 2-day national symposium that was held on rheumatology conducted by the All India Institute of Medical Sciences in Raipur. To give us more insights into this symposium, we have with us today the President of the Indian Rheumatology Association, Dr. B.G. Dharamanand. Welcome to Medical Dialogue, sir.
Hello.
Rheumatology is a specialty care of medicine that has emerged more powerfully in the last decade. So if you can just tell us how rheumatology as a dedicated field of treatment care revolutionized the treatment of the commonly encountered autoimmune diseases?
So, rheumatology is one of the youngest medical specialties, and in India it started somewhere around late 80s, and the first batch of trainees have started coming from early 1990s. So until then, rheumatic diseases were managed by physicians and orthopedic surgeons. And the rheumatic diseases, most of the rheumatic diseases are autoimmune disorders, and they require two different type of skills. One is diagnostic skill, which is not uncommon in a physician kind of a group, but a rheumatologist also has to be a chronic care provider. Many of the autoimmune rheumatic diseases were serious disorders and rapidly fatal disorders. Now, with the current management strategies, most of the patients are doing well, but we have made a serious disease into a chronic disease, and a rheumatologist needs to have the skill to manage patients on a long-term basis, because the diseases evolve, complications regarding the diseases, and also drug-related issues all require care, and that is why rheumatology as a specialty plays a huge role in many of the chronic autoimmune disorders.
Great. So talking about the recent national symposium on rheumatology that was organized by AIMS, what were the the new clinical management practices that were emphasized?
And the AIMS Raipur conducted a wonderful continuing medical education program for clinicians from Chhattisgarh. And rheumatology, as I told you, it is a still young specialty. And rheumatology is being introduced into Chhattisgarh in the recent 3-4 years. And the entire idea of the CME was how to make an early diagnosis so that the burden of inflammation comes down and the patients improve much better. For example, the early diagnosis was stressed in the conference. Any inflammatory diseases, if they stay in a joint or any organ long enough, can lead to permanent damage. So early diagnosis is the only way we can quickly control the inflammation and prevent long-term consequences of the autoimmune disorders. This is the theme which was stressed in the conference.
Great, sir. So we also know that reports have stated that there has been a surge in patients with rheumatology over the past few years. According to you, what are the possible reasons for it? That is, any risk factors or predisposing factors or primary co-morbidities that may be associated with an increased risk of autoimmune illnesses?
I'm not sure whether there is a surge or not. There is an increased awareness. When we started in 1996-97, and most of the clinicians thought that there won't be any patients for rheumatologists to see. And now we have more than 1,000 rheumatologists, all of whom are very, very busy, see 30-40 patients every day. So I think the main reason why there is a surge in the patient population is increased awareness. Once the rheumatologists are available, our rheumatologists are in the teaching faculty, and the rheumatic diseases are taught in the medical colleges, and more doctors are familiar with these diseases, and they make the diagnosis. Some of the diseases which were considered extremely rare in India, like lupus, sarcoidosis, are diagnosed on a day-to-day basis now. Environmental reasons as well. There could be an increased susceptibility to autoimmune diseases due to various environmental factors like a COVID infection. viral infections, pollutions, all stress, all of these things can contribute to development of autoimmune diseases. But the major reason why there are more patients diagnosed now is, I think, increased awareness.
Very true, sir. Even I agree that awareness does play a crucial role. The more people read about it, either through articles or various case studies, it is that people approach the rheumatologist for their early evaluation. In our country, we all started reading more about myositis when Samantha Prabhu, the South actress, suffered from it. So, what are the other such autoimmune diseases that are perceived as uncommon but are not so uncommon in a rheumatologist's practice chamber in India?
And thanks to her declaration of her illness and awareness about autoimmune diseases have increased in the population. And I think we should thank her for that. And myositis is indeed a rare disease. It occurs in not more than 1 in 5,000 population. So, in a rheumatology practice, it is very commonly seen because of the referral bias. But in a population, in a general practitioner, might be seeing 1 or 2 patients per year, and it's not very common. But without the knowledge about the disease, if the existence of disease is not known, they are not diagnosed. So there can be a huge diagnostic delay in many of these patients.
Agreed, sir. Also, as per research, we are aware that the impact of one specific rheumatological disease, that is rheumatoid arthritis, can be devastating. So, what according to you should be the primary goal of therapy to actually achieve early remission of this disease?
The most, as I told you earlier, the most important way they can achieve a good remission or control over the inflammatory disease is early diagnosis. And it may be difficult to make a diagnosis in the early stage because the initial symptoms can be vague. Patients can come with tiredness, generalized achiness, and fatigue. And the typical joint swellings might not be very obvious in the early few months of the disease. Once the joint swelling starts, then it becomes a little more easier, and the index of suspicion should be very high amongst the clinicians to consider this disease in patients presenting with polyarthritis. Poly means multiple joint pain and swelling, and an appropriate testing can confirm the disease. And early institution of appropriate and adequate treatment. Important is most people start them on treatment, but it is not appropriate or not adequate dosage and for the adequate duration. Then we can control the disease very well. And rheumatic diseases, particular rheumatoid arthritis, is very well known to produce a lot of deformities and dysfunction. But correct treatment, early diagnosis and early institution of treatment, we may be able to prevent these deformities and dysfunction and disability from happening in most of the patients.
So it all comes down, narrowing down to early diagnosis and treatment planning. So coming to the treatment aspect, rheumatology care usually involves the use of a lot of steroids, disease modifying agents, as well as biosimilars, which bring along their repercussions. What should be the guidance or playbook for monitoring physicians if the patient is not actually following up regularly with a rheumatologist?
Yes. So this is a very, very important and pertinent question because in good old days, in the absence of many medications, steroid was the mainstay and non-steroidal anti-inflammatory drugs, which are popularly called as painkillers, were used very, very commonly. And once we have discovered disease-modifying drugs and subsequently targeted drugs like biologicals and JAK inhibitors, the ability of the rheumatologist to control the disease very quickly and efficiently has improved. This has led to a significant reduction of usage of painkillers or non-steroidal, which we hardly use now, and also of steroids. In rheumatoid arthritis, there is no need to use steroids at all, except for few occasional patients. When a particular joint is very refractory, we can give intra-articular steroids. Or when the patient is very unwell, if the patient comes to me with a wheelchair, I might give him a very brief course of steroid because steroid works quickly. But it is the disease modifying drugs which are the mainstay of treatment of rheumatic diseases, particularly rheumatoid arthritis. In other autoimmune diseases like lupus or dermatomyositis or myositis, steroid still plays a role, but in the last decade or so, rheumatologists also have learned from their the past history, like in the last 20 years, 30 years, people are using very high dose of steroids, and we have faced the consequences of high dose steroids. And now steroids are used very minimally, very, very short period, and we quickly start them on disease modifying drugs or immunomodulators so that steroids can be quickly brought down to a minimum dose, which is quite safe to continue on a long term basis.
Yes, sir. Even for steroids, for that matter, the dosage needs to be tapered.
Yes, that's very important. Steroid, particularly if it is given for more than few weeks, it has to be gently tapered. Abrupt stopping can increase the disease. Disease can flare, and also our adrenal gland can get suppressed. And naturally, we all produce steroids. Without steroids, we cannot survive. But when we are taking steroid from outside, our body sees steroid in the blood and stops producing it. And if it is suppressed for long enough, it may take quite a long time for it to recover and produce steroid again. So you abruptly stop steroids and our adrenal glands have not started functioning again. Then you may end up with a state where there is an adrenal deficiency or a steroid deficiency, which can lead to sometimes life-threatening complications like hypotension and shock.
The next decade of pharmaceutical healthcare is believed to be the decade of emergence of these biosimilars, if we talk about it. So how would it impact rheumatology care, and what will be your message to the medical fraternity?
Biologicals have revolutionized the management of rheumatic diseases, particularly rheumatoid arthritis and ankylosing spondylitis and similar psoriatic arthritis, etc. But I want to insist that still the mainstay of treatment is conventional disease modifying drugs like methotrexate, sulfasalazine, leflunomide. They have to be used first, and at a significant percentage of patients can be very well controlled with this. They are very affordable, easily available, and works well for majority of the patients. In patients in whom we are not able to achieve an adequate control of the disease in the form of joint swelling, inflammation, or any other organ involvement, then the next step we can go is biologicals or targeted synthetic disease modifying drugs, which are small molecules which are as effective as biologicals. And biologicals can be classified into bio innovators, that original discoverer of the molecule. So they're called bio-originator biologicals. And after the patent period of the drug is over, and many of our Indian pharmaceutical companies are able to reverse engineer and produce a similar molecule, they are called biosimilars, which are much more economical than the bio-original molecules. So that makes these molecules much more affordable in our population, particularly in patients who are not able to afford the bio-originals. So biosimilars have made a huge impact, but I want you to know that most of the patients can be managed without biologicals or biosimilars with simple drugs which are very affordable and cheap.
That is great. Thank you so much, sir. Thank you for all your valuable insights. It was lovely to be interacting with you today.
Thank you very much. Thank you for having me here.
That's all for today. Stay tuned to Medical Dialogues for latest updates.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.